Okay, Mr. Adam, 23 years old, male patient, complain of chest pain. His vitals, his temperature 37.5, blood pressure 130/80, his respiratory rate 18, his pulse 100, saturation in room air 96. Okay, proceed, doctor.
Hello,
Hello?
I'm Dr. Ibrahim, one of the doctors of the clinic today. May I confirm I'm talking to Adam, 23 years old?
Yes, I am.
Mr. Adam, can you tell me what brought you to the hospital today?
For the last 2 days, I have chest pain.
Can you tell me any more about this pain?
Yes, I have chest pain in all my chest, more in my left side.
Is this first time you feel this pain?
No, it happened before.
How many times?
3 times.
When was the first attack?
Before 1.5 years.
Have you underwent any investigation before?
I went to ER and they gave me some medication,
Mhm.
then discharged.
And they didn't give you any diagnosis before?
No diagnosis.
What list of medication did they give you?
I
If you
cannot
remember.
remember I cannot remember at that time.
Mhm. And is this pain start all of sudden or gradually?
Sudden.
Mhm. And is it continuous or go and come?
No, it's continuous.
Yes. Can you give me the nature of this pain? Is it like feeling pressure or stabbing pain?
No, I feel it's like a stitching pain.
Stitching all over
Yes.
the chest?
Yes, all over the chest, more in the left side, more with taking breath.
More with taking breathing.
Yes.
And is there any associated symptoms like shortness of breath or
No shortness of breath.
and is there anything you feel improve this pain like a certain position or movement
No relation to any position improve.
or day or night?
All the day and night the pain is present.
The pain is present.
Mm.
And you didn't feel anything relieve this pain?
Like what?
Like any
I'm
lying
trying
flat,
some paracetamol like this, a little bit improve, but pain
and
still.
lying flat or coughing
No change in position regarding the pain.
or coughing or
No.
taking a deep breath
With deep breath increase.
with deep breath increase.
Mm.
Mhm. There is no any rash on your body or
No rush.
you don't feel your pulse or palpitation.
You mean awareness of my heartbeat?
Yes, awareness of your
No.
heart.
No.
You didn't feel like this before.
Yes.
And uh, and any cough,
No.
shortness of breath, no.
No.
Any joint pain?
Yes, I have joint pain.
You have joint pain. Since how long?
Since 2 days also.
2 days. Is there any swelling in your joints?
No, just aching.
Any special joint or it's a general?
I feel in my knee in my elbow also.
Knee and elbow. No skin rash, you said?
No skin rash.
There's no eye pain or redness?
No.
Is there any mouth ulcer or pain?
No mouth sores or no pain.
No pain. No coughing, cough, blood,
No.
or sputum. What about your water work? Is there any change?
Change in what exactly you mean?
Change in color or pain while you're doing your water work?
No change in pain, but I feel like foam on my water work.
Foam in your water work. And is there any abdominal pain?
Yes, I have tummy pain. Try to not to use jargon because this is against you.
Yeah. Yeah.
Okay? Yes, I have tummy pain.
You have tummy pain. Since how long?
2 days also.
Also 2 days. And is there any loose motions?
No.
No loose motion. And I'm sorry to ask, is there any pain or rash in private areas, genitalia?
No, I didn't notice this.
You didn't notice this. Any bumps or lumps under your skin?
No.
What's the site of pain of your tummy exactly?
All my tummy are aching.
Or your tummy?
Yes.
Is it come and go and also continuous?
Continuous also.
Continuous. And no vomiting,
No. No throwing up.
throwing up. And is there any difficulty in swallowing or pain?
No.
No difficulty in swallowing. Is there any loss of weight recently?
No.
And any feeling hotness?
No. You mean high temperature or weather preference?
Yeah.
Just to understand your question.
I mean feeling high temperature.
High temperature, yes, I had high temperature and I took paracetamol.
Mhm. Any recent travel?
No.
Any swelling in your legs?
No.
Okay. Uh, what about your past medical history? Do you have any admission before?
Yes, I was admitted because of this tummy pain and they did to me appendectomy.
Appendectomy.
Yes.
Since how long this was?
1 year back.
Is there any other operation
No, only appendectomy.
on the appendectomy? Is there any list of a drug other than paracetamol? You said.
No, I am not taking any regular medication.
Okay, I'm sorry to ask, but are you taking any recreational drugs?
No. But like what, doctor?
Like a heroin or coke or sniffing cocaine or something like this?
Okay, no, I'm not taking.
No. And can you tell me
Take care of
what's your
time.
concern?
Take care of your time, doctor. 9 minutes now.
Okay, can you tell me what's your concern?
What do I have, doctor?
I'm sorry for your suffering. Appreciate your feeling, but I still have to do an examination for you and send an investigation and imaging. After that, we can. I appreciate you. We will do our best uh, to to try to give you to reach your diagnosis.
Okay, doctor.
Okay. And now I want to ask you about your family history. If there is any similar complaint in your family, your
My brother has the same condition.
same condition, and
Yes.
your father and mother,
I have no idea.
You have no idea. Okay. Uh, what about your social history? What's your job?
I am a student.
Student.
Yes.
How is this pain affecting your study?
So much, doctor. I cannot go to my lectures and this.
Uh-huh. I'm sorry for this. I'll try to give you a sick leave, and uh, I will do my investigation. We'll do our best
Okay,
to
doctor.
reach you.
Thank you.
What about your driving, or are you smoking?
Yes, I'm smoking 10 cigarettes for the last 4 years.
4 years. Um, and we need from you to stop smoking, because it might affect your health, and sometimes aggravate some symptoms, some diseases. What about
Okay,
your
doctor.
do you drink alcohol?
No.
You don't drink alcohol.
Examine it, doctor.
Okay, I will do my examination now.
Okay.
I will start by the chest,
Mm,
and I'll start by observation of the hand. Okay.
okay.
And is there any change in the nails,
No change in the nail.
ocular nodules, or node,
No.
and any clubbing
No clubbing.
or palmar erythema?
No.
Pulse is regular, okay. And auscultation chest, is there any rub
No.
with heartbeat or with respiration?
Normal.
Normal. And in abdomen, is there any swelling or organomegaly?
No. No swelling. No organomegaly, but there is tenderness and guarding in his abdomen.
Tenderness and garden. What about eyes? Is there any jaundice or pallor?
No jaundice. No valor. No jaundice.
And what about the tongue and mouth? Is there any ulcers?
No.
And is there any lymph nodes
No lymph node.
and raised GVB?
No.
There is no raised GVB. What about the lower limbs? Is there any rash?
So now 2 minutes remaining, doctor. Okay. 2 minutes remaining. No rash.
Okay, no rash. Okay, we are going to do an investigation now, Mr. Adam, and we will send investigation for you, and imaging to try to find your diagnosis. Can tell me what other concern might.
No. What do I have, doctor? Same concern. You did not answer. What do I have now?
Okay, from what you said to me, and you have chest pain, and there's no relation to your respiration, and you didn't feel your pulse, but you have also abdominal pain and stabbing, and abdominal pain, and guarding on examination. There is a stiffness in your abdomen. I think you might have a vascular problem, but we have to do our investigation, and our investigation, and send images to confirm the diagnosis.
Okay, doctor. Time, doctor. Thank you,
Okay,
Dr. Ibrahim. So,
I was good.
summarize the case and give me what is the positive finding in this patient.
Okay, Mr. Adam, 23 years, has attacks of abdominal pain, and attacks of chest pain. This is third time in 1.5 years. It's 2 days duration, and has no relation to respiration, no relation to cough or position. And he also have abdominal pain, and abdominal pain and frothy urine, but no change in bowel habit. And there's abdominal guarding in examination. No any other signs in positive signs in an examination other than guarding and tenderness in the abdomen, and he has a history of appendectomy 2 years back.
So what is the diagnosis and the differential diagnosis?
I'm not sure but about the diagnosis, but
No problem. Take your time and talk. No problem.
I
The
feel like
the
it
the
might
main
be something related uh, to vascular problem or thromboembolic, but he doesn't have any previous history before.
okay, thromboembolic, one of the differential. You have to put thromboembolic causes or manifestation because of the presentation for this patient. But what is the most likely diagnosis in this patient? A recurrent attack of chest pain, abdominal pain, joint pain. There is fever, past history of acute abdomen.
Familiar Mediterranean fever.
Yes, okay. FMF, doctor, it's called
Yes.
recurrent polyserocytes. There will be inflammation in the serosa, in the peritoneum, in the pylora, in the joint, causing this manifestation. There will be recurrent chest pain, recurrent tummy pain. This is classic. Recurrent chest pain, recurrent abdominal pain, and recurrent joint pain, and there will be fever. Between the attacks, the patient is completely normal, and there is family history which support, because one of the criteria, minor criteria, is family history. Okay, so what is the mode of what you will want to put differential diagnosis if this is FMF?
Connective tissue disease, SLE,
Why SLE?
because it might cause abdominal pain and chest pain also. It might cause renal problem complication.
Okay, SLE can cause serocytes. Okay, but there will be another manifestation like skin rash. You asked about skin rash. What is the most common skin rash associated with familial Mediterranean fever?
Porphyria and acute
Porphyria is
intermittent.
another. This is another differential. You may put as a differential acute intermittent
Yes.
porphyria because there is a current abdominal pain and there is some. Also, there is family history. You should put also, but there is some skin disease commonly associated with FMF.
I don't know.
Okay, it's
Lichen?
called erysipelas. No, erysipelas. Erysipelas, this will be like cellulitis, but well-demarcated lesion. Well-demarcated lesion. Erysipelas is a common with FMF. Okay,
it's
what
not the
other?
one comes with the streptococcal infection, this? Or
Yes, can come with streptococcal infection and they can associate it with FMF.
okay,
And that's why you
erysipelas.
will give, yes, you'll give penicillin and this medication.
Thank you.
So, Dr. Ibrahim, what is the other definition? Now we put acute intermittent porphyria. You told thromboembolic embolism, yes, and you asked about pulmonary embolism. I feel from
Rheumatoid
your
arthritis.
question, you are trying to rule out pulmonary embolism, but you didn't ask about coughing up blood or
Yeah,
this is the only missing.
I asked about
Okay.
coughing blood.
You asked about swelling in the lower leg due to DVT, right? You asked about coughing up blood. Okay.
Yes,
And
I
you
asked
asked about
coughing.
awareness or fast heartbeat.
Yes, I
Okay.
asked.
Any other differential you want to put?
Rheumatoid arthritis might cause, even might cause pericarditis and might cause chest pain.
Pericarditis, there is pericarditis can be, but he will tell you, you ask it in certain position in improvement. Pericarditis improvement when patient leaning forward.
Yes,
Okay.
when patient
So
leaning forward.
I completely deny any positional pain.
Yes.
All right.
Yes.
Okay, so we put pulmonary embolism. You can put pneumonia also as a cause of infection. You can put acute intermittent porphyria. If this patient came with recurrent abdominal pain and there is family history and there is facial swelling, what do you think? If in the
Facial
history
swelling.
there is, yes.
Hereditary angioedema.
Yes, okay. Excellent, doctora. Hereditary angioedema. Okay, doctor. What is the mode of inheritance of FMF? Now we will give Dr. Ibrahim all his time as if he's in the exam to answer the questions.
No, I don't know. Sorry.
Okay, anyone want to
Somal
answer?
dominant. Somal dominant.
Autosomal recessive.
Dominant.
Autosomal recessive. Recessive.
Yes, autosomal recessive, yes.
Recessive.
Okay, Dr. Ibrahim. How you will approach for this patient? How you will investigate?
First investigation, I will do first the basic investigation, CBC and ESR and CRB, and urine, urea, electrolyte, and creatinine, and liver function test, and urine for investigation, urine for protein creatinine ratio.
Excellent.
Okay, after that, I will do chest X-ray and ECG. And might do ultrasound abdomen.
In basic investigation, you told me CBC.
Yes,
any
count is very important in familial Mediterranean fever.
What you may find in CBC?
There's eosinophilia usually and leukocytosis.
Leukocytosis, not eosinophilia. And in ESR and the CRB?
It is elevated ESR and CRB usually.
Yes, inflammatory marker will be raised. There is another
Yes.
one called serum amyloid A. Also, it will be raised in the FMF. This will be during the attack. One of the tests during attack will do serum amyloid A. It will be high also. Okay. Okay. So, what is the treatment for this?
Usually, the non-steroidal anti-inflammatory drugs is the main treatment of familial Mediterranean fever.
You insist that it is connective tissue disease. I don't know why. Not connective, not a connective tissue disease. Okay, it's one of the hereditary periodic fever. There is a mini hereditary periodic fever. Fever come and go, on and off. There is a wide list for this. The most common is FMF. Okay, so there is simple treatment we are giving to FMF.
Colchicine.
Yes, colchicine. You can give simple analgesic. Give colchicine if the patient refractory to colchicine or cannot tolerate colchicine due to side effect. What you will give?
Non-steroids.
No rule for steroid in this patient.
Okay.
Biological therapy.
Yes, biological therapy. Any name? Anyone knows the name?
Interferon alpha.
Interferon 1 beta inhibitor. Interleukin 1 beta inhibitor. Canakinumab. Yes, etanercept can be given also. Anakinra also can be given, but the most common is canakinumab. Okay, doctor, this patient, when you examine, you found lower limb edema. What do you think?
Lower limb edema.
In this patient, we are in the same patient now. What do you think the cause of lower limb edema for this patient?
Might be due to hypoalbuminemia. Due to
you are near close. Yes, there is
renal impairment.
Due to
renal damage.
Yes, amyloidosis. So I gave you in the history, don't expect this in the exam that the surrogate will be helpful. The majority of surrogate will tell you, I have no idea or I don't know. Okay, that I gave you when you ask about water work, as you said, you have to ask specified any change in amount, color, frequency, any frothy water work like this. But I gave it to you because you'll find frothy water work due to amyloidosis because they like this point in the exam. Colchicine, the main idea is to prevent amyloidosis. The mortality of FMF, the patient die due to amyloidosis. Okay.
Okay.
So amyloidosis is very important in this. Also, don't forget also genetic test. can we use for investigation, but this is very, very expensive. You can diagnose the clinical by criteria, one major or two minor. One major like this typical attack recurrent more than 3 with recurrent polypsychosis, or patient has fever or. And also in minor criteria, you will find a family history also. Okay.
Okay. Mark
Okay.
me now.
No, I will not mark. I think it is first time, Dr. Ibrahim, right?
Yes,
First
this
time.
is my first time.
So no problem. For first time, everything, the idea of practice is doing mistake here better than doing mistake in the exam, because
Yes.
here even if I give you a bad mark, it will not affect, but you have to do more practice, because to be, as we said before, professional in asking question, it will be targeted and organized. Know what you are asking about. Don't waste your time, because you took a long time in history. You did not examine until I told you examine the patient. In UK, we are answering the concern after examination. In Irish, because it's 20 minutes long, we can answer the concern before examination. This is two different points, okay? And don't forget to answer the concern. I said it many times. Managing a patient to concern equal for mark, equal history, equal examination. You told me before examination, you asked me what's your concern. I told you what do I have. You told me I want to do blah 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 blah, but you did not answer what I have. Then after examination, you told me, do you have any other concern? But you did not answer me the main concern. Okay.
Okay.
This is very important. Okay. Thank you,
But
Dr. Ibrahim.
if I didn't reach the diagnosis or possible diagnosis, or is it, am I, should I answer the concern? How? What should I say to the patient?
Most cases he will read the diagnosis. If you did not read the diagnosis, for example, you will tell the patient, I have a many possibility. At least you have possibility in your mind. You have some differential diagnosis, at least. So you'll tell like this. For example, we want to admit you and run some blood imaging and test to confirm our diagnosis. I have many possibilities in the form of blah, 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 blah. If you are not sure about the diagnosis. But in the majority, inshallah, it will be straightforward and it will be easy to be diagnosed. FMF is a very common scenario in UK and in Ireland. They like FMF. If I told you what nationalities present FMF more?
Mediterranean
Yes, from the name.
countries.
From the name.
Yes,
It is Mediterranean.
Morocco,
Area of the Mediterranean.
Turkey, Greece.
Okay. Do you know any other diseases can cause amyloidosis? And common also in our topic.
Renal failure.
No, there's some
Any
common
Rheumatoid
diseases.
arthritis.
condition, rheumatoid arthritis,
Rheumatoid
ankylosing
arthritis.
spondylitis.
Ankylosing spondylitis. One very common also. They like it.
One very common.
As differential or
Tuberculosis.
No, can lead to amyloidosis at the end.
amyloidosis? Yes, amyloidosis.
Yes,
Multiple
myeloma can.
myeloma.
Multiple myeloma can.
TB.
Ankylosing spondylitis can.
Ankylosing spondylitis,
Rheumatoid arthritis. And also bronchiectasis can lead to.
So, doctor, I'm sorry, you said multiple myeloma and bronchiectasis and rheumatoid arthritis?
Can lead to amyloidosis.
Okay, thank you.
Tuberculosis.
Yes, but usually in the exam, if you found bronchiectasis, FMF, he will touch always amyloidosis, because there will be lower limb edema. I will ask you why there is lower limb edema in case of bronchiectasis, okay? Or in case of FMF, why there is lower limb edema, where there is frothy water work. If the patient you are giving colchicine, why? You are giving him to improve the symptom and prevent amyloidosis, okay? The good thing, doctor, in your history, you divided in 3 parts. As we said, you tried as much as you can to cover the present history, which is the current complaint and analysis the complaint and related system. And you ask about past history in the form of family history and surgical history. And you did not forget the social, because this is very important. Social is one of the parameters you should cover, because you ask to offer help. How much is this impact? I think you did not ask this specifically, but you told me, I think I'll give you sick leave, right? Okay.
Yes.
Okay, thank you. Any question?
Thank you.
Anyone want to ask?
Can we keep sickle cell crisis in differential diagnosis?
Sickle cell crisis, maybe because of acute chest syndrome, and also can cause abdominal pain, and it will be recurrent, but this is thromboembolic. This is another, but you can put in differential. Differential you can put according to the symptom of the patient, or your sign you discover, or according to disease itself. For example, you enter the case and you are 100% this is fibrosis, but there is crepitation. So you can put other causes of crepitation in your definition. For example, this is find in inspiratory crackles, does not change the scuff. So I am 100% this is a lung fibrosis, but I can put other cause crepitation as a bronchiectasis or heart congestive heart failure or others as a differential. Why? Due to the sign and the scuff. Or I can put other due to the disease, which is fibrosis, other causes causing fibrosis, idiopathic pulmonary fibrosis or drug related, and so on. Okay.
Sorry, Dr. Talat.
Thanks.
There is difference from UK and Irish in the concern. I mean, the time or the answering.
لا, only in the timing, Dr. Ahmed, in the timing of a question. In Irish, we are asking the patient before examination usually. Okay. In the UK, you are always asking the patient when you hear there is 2 minutes remaining. You have to ask about his concern, because we said before at least 2 minutes you have to keep. Sometimes you may face the patient has many concerns. For example, he will tell you, what do I have? He will tell you, is it curable? Can it be like my father, he has cancer like this?
Okay.
Doctor, Assalamu
Yes.
alaikum.
Alaikum salam wa
Of course,
rahmatullah.
sickle cell, and I think sickle cell is not in the differential because he's 32. He's always, if he has a sickle, he's always already diagnosed. I think unlikely in the 62 years old.
No, for exam purpose, he don't want you to give the exact diagnosis. If you give the exact diagnosis, this is straightforward, okay. But you should put, as we mentioned before, a reasonable differential diagnosis, and it should be ordered and organized for the common and less common and less common, like this. Yeah, for example, if he put sickle cell crisis first differential, this will not be good. You should put at least pulmonary embolism first differential. Okay, you got my point, doctor?
Yes.
I mean, sometimes adding some differential, even in the fourth or fifth, better than you don't have any differential in your mind. Any other questions?
Doctor, investigation apart from the basic, there is any other investigation we'll do for this case?
The most diagnostic for this patient, FMF, during acute attack, there will be inflammatory marker, it will be raised, and there will be serum amyloid, it will be raised. Okay, there is no specific test. If you want to do, you can do the Mediterranean fever gene test, but this is very expensive. You got my point. You have patient with recurrent attack and has family history, and there is his chest and abdomen and the joint aching. Start about 2 to 3 days like this, and then between attacks is completely normal. So clinically, you can diagnose this patient.
Thank you.
What is the name of the test, doctor?
MEF, Mediterranean fever V test, genetic test.
Genetic test.
Yes, genetic test.
Thank you.
Any other question, or go to the other case? It will be short. Okay, Dr. Sousan there?
Yes, doctor, I'm here.
Okay, Dr. Sousan, I will stop this recording and I will do another recording to be twice. I think I found some like short to review for easy for watching, I mean.
Okay.
Doctor, there will be another scenario now?
Yes, there will be another scenario, but I will stop to divide the video. So this it will be very long sometimes.
Okay, yes, doctor, sure.
People feel bored.
So
Okay.
it is LCC, doctor, or communication?
No, it will be short clinic.
Okay.